Our February 23rd, 2022 work session of the Douglas County Board of Commissioners. I will let Sarah give a little bit of introduction about this and introduce our guests.
Thanks, Commissioners. Our work session today is on the Certified Community Behavioral Health Clinic, which I want to call it center. System, and we've got Bert Nash here and a host of folks to kind of walk us through the presentation. Just a reminder to anyone who's listening or in the audience that these sessions are for informational purposes only. No action is taken at these meetings, and there's no public comment. So with that, I'll turn it over to Patrick Schmitz with Bert Nash.
Thank you, Sarah. Hi, Jill. How are you? Thank you, Commissioners, for the time. This conversation's been a long time in coming. You've been wanting some information on it, and as we've worked with the state as they've gone through their process to get things prepared, we've had to kind of wait a little bit so we get a little bit more information. So thank you for your patience with that. I am going to see if I can remember the instructions from last week on sharing. That's too big. First. So thank you again for the opportunity to come talk to you about what really has been suggested as probably the most significant change in the mental health services arena in well over 30 years. The impetus for the certified community behavioral health clinics started about 10, 12 years ago at a national level. When it was decided that under the Excellence in Mental Health Act, that the federal government needed to do something to better support community mental health services, not only in terms of the service array, but also how the payment and evaluation of those services occurs. And so that's when this movement started. And I remember many years ago going to Washington, D.C. to advocate for passage of the Excellence in Mental Health Act. So I've been waiting for this to come to a state near me for a long time, because we tried to get this started in Iowa. Just at the same time, Kansas was thinking about it many years ago. And thankfully this last year, we were able to get that accomplished through the efforts of many, many individuals. I will present a few of the slides, and then Stephen will come up. We'll have Marcia come up, and also Sarah Bishop, who's our consultant from Coneflower. That way you don't have to listen to me the entire time. Also, Commissioner Brown from KDADS is here to help answer additional questions. He has been a huge resource and probably one of the main reasons we were able to get Ccbhc legislation passed here in Kansas. So I definitely want to thank him for being here, but also the work he did to make it happen last year. So let's get started. But first, a quick that's what we're going to try to cover today. I won't read that out to you. I think you also have a copy of the presentation, but we'll try to answer all of these questions and many more that will come up during the course of our discussion today. Backwards. All right, so let's understand first quickly what a CMHC is. Kansas statute requires counties to ensure that there is provision of mental health services to the citizens of their county, either directly by establishing those services as a county-based service like you see in Johnson County and Sedgwick County, or through arrangement with a CMHC. And there are 26 CMHCs in Kansas. There are only 2, I believe, and Commissioner Brown might need to correct me, but I'm only aware of 2 that are county-based. The rest are CMHC standalone, private not-for-profit entities. A community mental health center is a mental health organization charged by state statute with being a legally designated authority. The mental health authority provide the mental health care in Kansas counties or the counties they serve. There are some CMHCs that serve 2, 3, 4 counties. There is one that serves 19 counties up in the northwest corner, or let's maybe say the northwest half of the state. It's pretty large. In addition to a full range of outpatient clinical services, what sets CMHCs apart is the comprehensive mental health rehabilitation services such as psychosocial rehab, community psychiatric support, and treatment, peer support, case management, and attendant care. Those are some of the things that we are mandated to provide and that only CMHCs can provide. Services and additional services must be provided regardless of an individual's ability to pay. So we don't turn anyone away regardless. And as I mentioned earlier, we are one of 26 here in the state. What's different about moving into a CCBHC model is the structure, the arrangement, the payment. It is a behavioral health clinic that receives special certification from the state for its efforts to coordinate healthcare experience for its consumers. We do a lot of that now, but this becomes a key component, as you will hear, and as Commissioner Brown will probably add. Care coordination becomes a significant piece, as well as integrated care. It is built on a threefold mission: integrated clinical services, so trying to provide a more robust array of services for the client when they come through the door. It also adds financial sustainability, and it's aimed to provide the more a better way of accounting for the entire cost of providing care and reimbursing you for that better. Now, it's not going to solve every financial issue, but it's going to help significantly. Third component of it is the evaluation of that integrated care system. So a big piece of what we do and will be doing under a CCBHC is adding a lot of evaluation to what we're doing, data gathering, evaluating the outcomes, making sure that what we think will work and are doing actually is having the impact. And if not, what are you doing to change that and make it a better level of care? That's yours.
Hello, I'm Stephen O'Neill. I'm the Chief Operations Officer at Bert Nash. What's exciting about CCBHC to me, I've been in community mental health for, this is my 20th year. It's literally all I've ever done. And it never made sense to me when I was a case manager and a therapist, what the activities, it's as if we were building widgets because the way that we were paid was by producing units of service, and we had to produce X number of units of service in order to cover costs. And the units of service were not reimbursed in any way tied to any rule of economics that I've ever learned about, because currently actually our lowest paid staff generate the most revenue and our highest paid staff generate maybe half of what it costs to support them in the case of a psychiatrist. So it was really challenging, and it was hard to get people what they needed. And there was a lot of pressure on providers to make widgets with people rather than to really ensure that folks were getting what made sense to them. The other thing that never made a lot of sense to me is how the system of getting help was organized. Oftentimes an individual person may have to go 4 or 5 or even 6 different places to have their various needs met, rather than having the care integrated around the patient. CCBHC is a service model that attempts to really integrate care around the people receiving that care so that they're not having to navigate a system by going to 4 or 5 or even 6 different places. And it ties the funding together rather than producing widgets. It actually is tied to the cost, which I'll talk about in a second. But there are very specific services that a CCBHC has to provide in order to be certified. The state of Kansas, and I'm sure Commissioner Brown will talk more about this, has adopted the federal approach to CCBHC. I think the state felt that the best way to get the state plan through CMS was to really align with the recommendations and approaches that were coming out of SAMHSA. And there are 9 core services that a CCBHC has to provide. 4 of those services must be provided directly by the CCBHC, and that is the screening, assessment, and diagnosis of behavioral health issues, including substance abuse. So one of the biggest challenges I think this will solve is integrating an artificial split between mental health and substance abuse. At the state level, people do not experience their health separately. We experience it. It's not compartmentalized. Historically, at the state level, really all over the country, we have separated substance abuse and mental health. CCBHC undoes that and brings that back together and brings the funding for those systems together. We also have to provide patient-centered treatment planning, comprehensive outpatient mental health and substance abuse services, 24-hour mobile crisis and crisis stabilization services. So here, I think our county, the commission, the county staff, all of our BHLC partners can stand tall, knowing that all the work that we've done here over the last several years has positioned us to be ready for this. Had we not done all of the things we had done, we would not be nearly as ready as we are today. So those are the 4 services that a CCBHC has to provide directly. There are 5 other services that we can directly provide or partner to provide. The first is psychiatric rehabilitative services. That is primarily the services we provide today for adults with severe and persistent mental illness and children who, I really don't like this label, but severe emotional disturbance is the label, or SED. Peer support services, targeted case management services, primary health screening and monitoring, because another goal of the CCBHC program is to integrate primary care into the behavioral health clinic and integrate behavioral health into primary care, and then armed forces and veteran services. I would say, and Commissioner Brown might address this specifically, but due to where we're geographically located, the priority need for us to provide those armed forces and veteran services is probably not as high as some other areas in the state, because we are so geographically close to several VAs, but we will still be putting resources and time and energy into making sure that we're equipped and ready to serve that population.
Stephen, can you
Yes.
go over a few? You're using a lot of acronyms. So
Yes.
Yeah. So you said CMS and
Yes.
SAMHSA, and I know that we know that, but in case anybody's listening, can you go over
So,
that?
Yes, Commissioner Kelly. CMS is Center for Medicare and Medicaid Services. And that is the federal agency that is responsible for approving the state's Medicaid plan and the CCBHC plan. And SAMHSA is the Substance Abuse and Mental Health Services Administration, and they are releasing a lot of the guidance on what it means to be a CCBHC and that certification criteria. Did I use any other acronyms? I apologize for that.
I didn't hear any others that you hadn't defined. Those are the 2 that
Okay.
jumped out at me.
Yeah.
Thanks.
I think Patrick mentioned that CCBHC is going to fundamentally change the way that we're paid. So the way that it works right now is we are paid per unit of service. So if it's typically done in 15-minute increments of service, and that is how we are reimbursed. So we document our interventions and those bill out and we get paid for those. CCBHC will change the way we are paid for some of the services, many of the services we provide. Other services may continue to be reimbursed on a fee-for-service rate. Certainly our commercial insurances are going to continue to reimburse us on a fee-for-service rate. We may have other payers that do that, such as Medicare. But for our Medicaid population, for many services, it's going to shift into the daily PPS, prospective payment system rate. And what that does, and states have two options for establishing a PPS. Kansas, I believe, is pursuing what's called PPS 1, which takes your total annual allowable CCBHC costs. So it takes all of the costs associated with providing CCBHC services, whether it's to someone with Medicaid, someone who doesn't have insurance, or someone who has commercial insurance, and it adds up all of those expenses and it divides it by the number of annual daily CCBHC daily visits in a year. So every mental health center is likely to have a different rate based on the variables at play in their community and the cost it takes to serve their community. It is likely our rate will be pretty high because we have a crisis center, and that crisis center is highly likely to be rolled into the PPS rate. So what this means is, whereas now we get 15 minutes of service, we get 15 minutes of pay. Now, if an individual gets case management from Bert Nash, it will trigger that PPS rate, and that parts of that rate will have to go to all the component parts of the system. If that individual gets 6 services on the same day, we still only get the rate once. It only triggers the rate once. So in our system, if someone gets an hour of peer support, that triggers the PPS rate, for example, and a portion of that would go to support therapy, psychiatric services, the crisis center, which is very, very different than how it happens today. Now, if someone without insurance comes in or with commercial insurance, that would not trigger the rate, but it wouldn't trigger the PPS, but the cost to serve those people was built in and accounted for in the rate. So we will still need support for the uninsured, and it'll still be critically important for us to be successful in negotiating with commercial payers to adequately reimburse for service. This could be a whole other presentation, but actually in the state of Kansas, Medicaid is one of the best payers, which is, again, a whole nother presentation. So that is kind of how the payment system will work. It's fundamentally different, and it creates the opportunity to do things that we don't do today, and it more closely aligns the revenue with the expense. And in our current system, the revenue is not aligned with the expense at all, because right now a case manager has to produce a lot of widgets, not just to pay for themselves, but they have to pay for the psychiatrist, for Stephen, for Patrick, for Marcia, for our front desk staff. This more closely aligns that, because we can build a lot of those services into the model, and it should create a much stronger, much better behavioral health system. I do want to clarify before I hand it over to Marcia, though, that while Bert Nash will certainly be evolving and expanding greatly the number of services we provide and types of services, CCBHC is not meant to supplant or replace existing programs and services in a community, particularly those that are working well. It's designed to enhance those. And that's why the DCO mechanism exists and the care coordination partner mechanism exists, because communities will be able to leverage existing resources that are working well. So I did want to clarify that, because often in communities, that's a concerning point for organizations that aren't the CCBHC on the impact that it will have for them. Thank you. And I'm going to hand it over.
Yeah, Stephen, maybe just a quick question. You know how I love these numbers, and this is such fascinating, interesting change to how you all
Yes.
have been paid. So it sounds like, I mean, this rate just becomes incredibly important to
Yes.
how your whole funding mechanism is
Yes.
structured. Is that approved? Is the rate then approved by the state? And
Yes.
And is it reviewed on a hopefully semi-regular basis if costs change and those kinds of things happen?
Yes.
that's-
So we'll set our rate here over the coming months. And then we would review that rate, I think after our first year. Is that right, Commissioner Brown?
Okay, yeah,
And,
thank you.
but you're right, Sarah, getting the numerator and the denominator right is critically important. Bert Nash is contracted with Cohn Resnick, which is a national consulting firm, to help us get that number right. Because we can't afford, our community can't afford to get it wrong, especially with the number and complexity of projects that we have. That's an excellent question. Any other questions before I hand it over to Marcia? All right. One of the other investments we made was promoting Marcia Page White. She's our Senior Director of Innovation and Implementation. I wish I had any of those words in my job title, but Marcia has over 25 years of experience in behavioral health, both in mental health and substance abuse. And prior to moving to Lawrence, actually worked for one of the first CCBHCs, Rediscover Mental Health, in the state of Missouri. So we're really lucky and fortunate to have Marcia here. So I'll let you. And then I did. I have these behind Sarah. You can figure it out. Up in there and the comments for.
So like Stephen said, I'm Marcia Page White. I did come from a community mental health agency in Missouri that was a CCBHC model. And I was able to see just the difference going to that made for the services that we provided and the services that our clients were able to receive and benefit from. So I'm super excited that Bert Nash is moving towards the CCBHC model, and I'm excited to be a part of it. Although Stephen did twist my arm for it. So I want to talk a little bit about what a designated care organization is. And you might hear us refer to this as a DCO. So DCOs are partner organizations that directly provide one of those 5 services that we had talked about earlier in a contracted agreement. So if in the review of us taking a look at our services, we recognize that there's a service that can be provided somewhere else or better served, we can make a contract with those folks, include that information into our cost report and go there. If we choose to move to a designated care organization or DCO, there's some requirements. So they have to have at least 2 years of experience in providing that relevant service and meet all state applicable licensing, accreditation, and certifications. So whatever Bert Nash is a part of and what our certifications are, they need to be able to match that as well. We'll have that agreement in place for the delivery of services to those CCBHC clients. So if we use a DCO, and they provide a service for us, then we are, that's a part of our PPS, and we're responsible for paying them through that PPS agreement. And so the whole part of the CCBHC and the PPS includes that DCO arrangement as well.
This is Commissioner Portillo. May I just jump in with a quick question on that?
Sure.
So Stephen mentioned that part of why the daily rate will be significant for us is because we have the crisis center. So the crisis center, because it is a separate organization, would be one of the DCOs that Bert Nash would partner with. Is that?
Yes. Yes.
Sorry.
So the treatment and recovery center is kind of a complex animal. Our hope and our proposal would be that since we legally control 50% of the entity along with LMH Health, that 50% would be enough that we would just include it in the PPS rate and not have to do a DCO agreement, which would save a lot of additional expense and extra work. I think that would be the state's preference as well. We would, of course, have an internal process to make sure the money that needed to go there. But the TRC, I think we're going to try to, I mean, it is an extension of Bert Nash. And the other thing is the services it provides technically don't fall into a category that we can DCO out anyway. The CCBHC has to do those services. So hopefully our proposal that since we control 50% of it, that works. Otherwise, we would then have to work through how we would meet the requirement to provide those core services, because that is not something we would even have the option, I don't think, and Commissioner Brown can elaborate on that, to contract out to another entity.
I am all for the lower administrative burden of
Yes.
discounting it directly. I just wanted to make sure since
Yes.
they're
but
different entities, but similarly controlled, that we know how that'll move forward.
Yeah, the TRC is awesome, but its awesomeness also adds to its complexity, but we will work through that.
And just a quick update, we actually have a meeting on Friday with KDADs to talk specifically about this. So we'll know
Fantastic.
more after Friday.
Thank you.
Can I ask you, Patrick, to drill down maybe into another example? Just as I'm trying to think about this, the county funds case management through Heartland, right? And case management is here. So would now that be a partner through Bert Nash?
Here's the challenge. We often use same terms to describe different things.
Okay.
And so as I understand it, the county has an agreement with Heartland Rate Act to provide care coordination.
Okay.
And that's a specific service. It can be similar to some of the work that we do as a case manager. And targeted case management is yet a different kind of service. So there's some nuances there. But if Heartland, we're going to continue that work, we want to say, hey, how do we get them? So the federal government's paying for that versus Douglas County. So Douglas County could take that money and create other new cool behavioral health programs. Then we would have to figure out a DCO arrangement, how it fits in there, and work that out. But that's part of the cool thing about this opportunity is you get to be super creative in a good way, not in a bad way, super creative in how you pull together a variety of services that best meet your community's need and have the federal government help you pay for that better.
So just to follow up, are there any services that you're thinking that the county usually has typically paid for in the past that you're seeing like this could go under a DCO and we would then charge the federal government instead of local counties?
That is a review we are currently undertaking.
Good questions. Thank you. Oops. I went too far. So the other way that we can leverage services across our community is through the care coordination partnership. So the care coordinator partnership provides any one of the spectrum healthcare safety net services, including services like inpatient care, primary care, and housing access. The care coordination partners commit to working with the CCBHC to help coordinate the care across the organization so that consumers have a more integrated experience. The care coordination partnerships are structured as a referral agreement and nothing material value is exchanged between the CCBHC and the care coordinator partnership. Whereas the DCO, those services fall directly under what we would be doing in the CCBHC. There's a partnership, there's a contract with that. There's a provision for money and they have to follow our standards. It's not the case with the care coordination partnership. They have their own standards, their own services, and we just partner with them. I'm going to turn it over to Sarah and then I'm going to come back. So.
Okay, hello, I'm Sarah Bishop. I'm with Cornflower Consulting, and I am the grant consultant on this project. As all of this goes to show, we are really in the process of two different certification or application processes right now. So on May 3rd, 2021, Governor Laura Kelly signed legislation, namely Senate Substitute for House Bill 2208, to establish the Certified Community Behavioral Health Clinic as a new model for providing behavioral health services in Kansas. This is a huge shift for the state. As we've been talking to consultants from across the country, they have been very, very impressed by Kansas's ability to implement this change and to implement it so quickly. So thank you to Commissioner Brown and to everyone else who's helped to get this process started. We're very excited to apply for certification over the next several months with the goal of hopefully receiving CCBHC certification in late summer, early fall of 2022. We'll be pulling letters of commitment from our various partners as we go through this process. And of course, we're learning more and more along the way as we continue to work on that application. The other application process that we're going through right now is a SAMHSA, or Substance Abuse and Mental Health Services Administration grant. They offer CCBHC expansion grants, which help new CCBHCs more quickly afford the infrastructure, staffing, and programs they need to create the integrated behavioral healthcare system they anticipate. So this is funding up to $2 million a year for 2 years that would be coming into the county to help integrate our behavioral healthcare system and to make sure that we are doing the things that our community needs to have the best, most integrated behavioral healthcare system possible. We are waiting for these grant guidelines to drop. They were slated initially to drop December 30th, 2021. Unfortunately, they have yet to be made public. We're expecting them to drop any day. I'm checking grants.gov daily, but they have not dropped yet. But as soon as they do, we'll know a lot more about what is required for that application. Thank you.
So, oops, keep going too far. So as we move through this process, I think it's really important to think about what we want in this community and how we can get that. We need to be able to dream big and take a look at what services that you can envision that maybe we can incorporate into our system of care. We need to know, like, are there, do we have everything that we need? Are there infrastructure costs we should consider? What about training? What about staff? Is there a service need that you say, gosh, who's providing that in this county? And the answer is no one, and we need some help with that. So I actually have a little bucket list started. I've got a little folder, and I've had people, as we've had these conversations, like, what about this? And what about this? And what about this? That's what we need to take a look at, because over the next several years, as we continue to work through this whole process of CCBHC and continuing to add and grow, I want ideas. I want to look for opportunities out there to add to our system of care, to figure out how we partner better with that, how we make Douglas County the best place to live and get services for everyone across the spectrum who's in need. So we want ideas, we want, thoughts, questions, like, has anybody thought of this? Have you, had any ideas about this? So any ideas about that to help us, we want to hear about. So I think that's what we have. I know that Commissioner Brown is here, and I want to give him an opportunity to talk as well. So turn it over to you.
All right, I'm gonna go ahead and stop sharing since I didn't bring slides, but my name is Andy Brown. I'm the Commissioner for Behavioral Health Services at the Kansas Department for Aging and Disability Services, and I've been in that role during the months leading up to the Kelly administration and since then. I want to start by saying that I'm happy to stay here all night talking about this and answering questions, so feel free to lay them on me. But I want to emphasize the level of challenge that the state is facing regarding CCBHCs. So this legislation came about through recommendations from the Kansas Mental Health Task Force and from the interim Mental Health Modernization and Reform Committee of the legislature. The bill was passed and signed by the governor, and it created funding for the agencies to implement this. During the course of the working on it, we really tried to reinforce the size of the task in front of the state and being able to do this and asking for an adequate amount of time to get all this implemented and rolled out. And the legislature gave us a fairly short timeline in reality. So we hit the ground running in May last year and started working as hard as we could to get ourselves in a position where by May 1st, we'll be able to certify the first 6 CCBHCs here in Kansas. And part of the reason this is a big task is because while CCBHCs have been around and been part of the Medicaid system for about 10 years, they've only existed as a demonstration. So if we are successful in what we're attempting to accomplish here in Kansas, we'll be the first state in the country to actually implement CCBHCs as part of our state plan for Medicaid. And what that means is that right now there are all kinds of eyes on us from all across the country waiting to see how we do this, because there are 25 other states and territories that do not currently have a demonstration. And this will really be a big win, I think, for Kansas if we're able to successfully pull all this off. One of the things that we started out immediately doing was we sent out a survey of the CMHCs to kind of tally what portions of the CCBHC requirements they were already providing in their communities, and also looking at what their intention was around when they felt like they might apply for certification to the state. And I'm happy to report that, Bert and Nash had a lot of those check marks already checked off, in a large part due to the support that they received from the county here in Douglas County. And this is one of those areas where I feel like the community has been moving in a parallel path to what we've been doing at the state level. And we're about to reach a point where our train tracks are merging, right? And so I thought it was important today just to come and answer questions that you guys might have and support Bert Nash and their efforts to provide some educational opportunities to the three of you and to the staff about what CCBHCs are and how they work. And there's a few things that I wanted to kind of dive a little bit deeper into today. I think Bert Nash did a wonderful job on their presentation. There's a lot of good information in there. But you can see there were several questions that came up and they were kind of like, well, maybe Andy might know more about this or that. So I'll try to cover those. I'll try to answer your questions. And our system, our choices that we've made as a state, right, are based on a couple of things. One, we wanted to try to keep the process as simple as possible because of the amount of time that we had to implement, right? So as a result of that, we decided early on that we were going to stay as true as possible to what the demonstration states were requiring under their CCBHC criteria. That'll hopefully allow us to successfully get our state plan approved in a short amount of time without a lot of back and forth between the federal system and our state system. And so that means that in addition to those criteria that were talked about in terms of the core service areas and what are required services of CCBHCs, we also have made some choices about how we're going to implement that here in Kansas that are based on the demonstration states. And so one of those things is that we chose the PPS 1 rate. And that PPS is a daily rate. And as Bert Nash was explaining, that is a cost-based report, right, that the agency puts together and submits to the state. And then our auditors and our rate reviewers will go over that report. And we take all of the eligible costs that the CCBHC can claim, plus any expected costs or anticipated costs for their first year of operation. And we review those and we come up with a dollar amount that's agreed upon as being the cost of operation. And then that amount is then compared to their estimates on how many encounters they think that they will have with members that have a Medicaid policy. And then that amount is divided, right, to come up with what the dollar amount will be for the PPS 1 rate. And what that does, and I think Bert Nash did a good job of describing this, is it allows us to include the costs of services that are kind of above and beyond what that individual encounter might incur. And that allows for quite a bit of flexibility in terms of how the overall funding stream of the agency works. But what I want to kind of zero in on is, when we talk about the funding that the county provides to the agency and how that supports what's going on with the center and what the state provides in terms of services, funding for services to the uninsured. Those dollars can be sort of reallocated and spread out within the system, meaning that, for example, Patrick, I think you mentioned that you had some contract with Heartland. It's possible to look at overall how your behavioral health system is set up in the county and identify that there are certain costs that the county is incurring and possibly reallocate those across the system in a way that would allow you to then perhaps receive an enhanced, or not even enhanced, just a federal match from the Medicaid program for helping with some of those costs. And so we're anticipating that most of the CMHCs around the state will have an increase in their Medicaid funding from the CanCare system of about 25 to 30% across their total annual income from Medicaid. And so we don't have those specific numbers yet for Bert Nash because they haven't quite gotten to the point where they're doing their cost reporting yet, but you can kind of envision what a 25% increase in their largest funding might look like, right? And that can allow some flexibility for other projects that the county's working on around behavioral health. And then I also wanted to talk a little bit about the DCO relationship. So there are those core services that are required. There's 4 of them out of the 9. And I think Stephen pointed out that crisis services is one of those. But so is so are the outpatient SUD services and the detox services, right? And so there's a number of those that might look a little different under the lens of CCBHC than they've looked in the past as Douglas County has been planning how things might work relationship-wise between providers within the county. And Bert Nash was also very accurate in stating that those DCO relationships are partnerships where the provider or the CCBHC, right, is contracting with a second provider to cover some of their required services. And so when that relationship exists, it's between the CCBHC and that provider to contract whatever rate they would pay for that particular service. But regardless of what contracted rate is negotiated, Bert Nash would be paid the PPS rate for those encounters. And so that allows for some negotiation and flexibility again on the income side for Bert Nash as they're working to develop those relationships and cover those required services. When there's a relationship where someone is being referred out for a service, but there is no contractual expectation, then those relationships are not considered DCOs. And there's no expectation that there's any financial back and forth between the person that's receiving the referral and the entity that's providing it, or the CCBHC. And that's the cleanest way to think of the difference in my head. Is it comes down to, you know, are the services that are being provided part of the required services? Is the CCBHC providing those, or are they being provided by another agency? And then is there a contractual expectation that the third party receives payment from the CCBHC for those services? If they're going to bill on their own, there isn't a need for the DCO relationship. And then the other part of that that's just a little tricky is that the core services generally cannot be provided by a DCO. They have to be provided by the CCBHC. And I think that's where things are going to get a little tricky here in Douglas County. We're going to have to really examine how those relationships are being set up and make sure that they fit in the overall vision of what the county has been planning and working on for the last several years. You know, I talked to Bob Triansky a little while ago about the fact that none of us knew that CCBHC was going to happen when we made a lot of the plans that we've made here in Douglas County. That doesn't mean that the plans are bad or that we need to throw them out the window. We just need to make sure that we are looking through that CCBHC lens at them and identifying the way that they can best fit that model for reimbursement. And hopefully that'll overall be a benefit to the county and to the people that live here and need the services. And then I think maybe the last thing I want to try to provide a little bit of explanation about is just that as we were going through this process, one of the things that the state is intending to do is to work on establishing some additional things down the road, right? So one of the options that states have are based around quality-based reimbursements and ways that we can incentivize better use of evidence-based practices, higher response times, you know, shorter waiting periods, those kinds of things, all designed to really increase access to better services. And so those value-based reimbursements, we are leaving out of this round of what we are doing with CCBHCs because it would add an additional kind of layer or wrinkle to our state plan amendment. But we do intend in the future to go back and revisit that because we do feel like it's important to incentivize the providers, not just to get that enhanced PPS rate, but also provide them with recognition for the services that they're providing when they're at a higher level. And I think with that, I've covered everything I felt like I needed to cover, but I'm happy to stand here for a while and take questions.
Thank you. As Commissioner Reed here, I really appreciate the thorough presentation and walking us through all the elements. I wanted to kind of go back to the beginning of the presentation when we talked about the kind of three primary pieces of a CCBHPC, BHC, I'll get the letters right. The third one, the evaluation of integrated clinical care system. Were you able to elaborate more on kind of what the expectation is about how that, what does an evaluation look like? What kind of surveying of folks across the community does that look like? And I guess also if you have any sense of how, at what point in the timeline is that sort of triggered, right? Because there's nothing to evaluate at the very get. I mean, there's a lot to evaluate in building it, but how frequently do we know that process to be?
Yeah, well, there's for starters, there's a needs assessment, a community needs assessment that's done by the CCBHC to help identify what services they feel like are prospectively needed in the community. So at the front end, initially, you're making some decisions about anticipated costs, new programs that you might need to develop, new staff you might need to hire. And so that community needs assessment helps identify, maybe the number of encounters you're going to have, the types of services that might be needed that don't exist today, anything that is an expansion of the current services. And then once that assessment's done, really where the care coordination really starts to go into play is when people interact with the CCBHC. So the CCBHC is required basically to provide a service to anybody that comes through the door, and they're required to provide all 9 of those services or have a contractor that will provide that service. And so there are, in terms of the integration, you'll have some primary care screenings that are done, right? Some things that will be monitored around primary care, and some referrals and coordination with primary care providers to make sure that people with severe persistent mental illness or substance use disorders are receiving that kind of care. There's requirements for tobacco screening and cessation services. There's a significant amount of the SNPI population that continue to be regular smokers. And we have a higher incident of death sort of related to smoking amongst behavioral health patients. And so that's an area that would be screened on a regular basis, but you're looking at like blood pressure, urine screenings, things like that, that help with primary care screens and diagnosis so that they can have proper referrals to primary care and that care can be coordinated. There's also integration on the SUD side, and Stephen kind of mentioned that a little bit earlier during his presentation. But the idea really is to make sure that anybody that comes through that front door, regardless of what their diagnosis might be, that they're able to receive those outpatient services through the center. If they need crisis services, that those are available on a 24/7 basis. And then if there are additional services that are needed in an inpatient setting or something like that, those would be referred out to an inpatient provider. And so ultimately, the integration is about making sure that everybody has care coordination and that the CCBHC is able to track the needs of those patients.
Thank you for that. I wonder, I'm just gonna build on that a little bit and ask do you know if part of the evaluation process will specifically involve soliciting feedback about services received from patients? Will that be an integrated part of services that they're getting? I see Stephen is stepping forward. and
Yeah,
maybe he has something to
feel
add
free to
too.
jump up here, but I think the answer is yes. Yeah.
So Commissioner Brown can speak a lot about what they're doing at the state. I can speak very specifically about how we're handling that at Bert Nash. So we have at least 3 legs to the stool right now, and CCBHC's one, our national accreditation through CARF is the other, and our strategic plan is the third. And evaluation and outcomes is a significant part of that. So underneath those 3 things, we have what's called measuring program success. That's our internal document. It's about 60 pages of outcomes and measures by team and by business function that we're measuring. A significant piece of that, both tied to CCBHC and CARF, and because it's the right thing to do, is engaging with the folks we're serving, soliciting their feedback on services. We actually had our highest ever response to our client satisfaction survey this year. I can't remember the exact number, but we're getting better and better at that. We'll be doing focus groups and getting feedback in all kinds of ways. But the voice of the consumer is like one of the cornerstones of CCBHC and one of the cornerstones of CARF. In fact, the CCBHC's board has to be populated by a specific percentage of individuals who actually receive services from the CCBHC. So your question, Commissioner Reed's a really good one. And I think you'll find it's like at the foundation of what we're trying to accomplish and do. So hopefully that helps.
That was great. Thank you. That's exactly what I was hoping to hear, and got the sense that that was kind of baked into the foundation of it, but wanted to know that that was a specific focus area. And also, you answered my question about wondering if patients or consumers would be a part of a new board structure. So
and so there's the requirement's 50%, 50% of the board. And you know, for the CMHCs that have you know, like a county governance, right, where like the commissioners are actually the board, they can have an advisory board that then has that 50% makeup. And so one of the other things that I'll bring up around the sort of the quality and the engagement with the consumers is that there's a quality assurance team that the state is building that will have fidelity reviewers that'll be able to come out and review fidelity to certain EBPs. To check and see if those are being followed or if there's things that need to be enhanced in order to get them up to fidelity standards for those particular practices. And almost all of those EBPs have, you know, a feedback component where they look at what the patient's experiences are, what their feedback is about the program, and what their overall benefit and outcome is.
thank you. Commissioner Portillo or Commissioner Kelly, do you have further questions?
So Commissioner Brand, you sort of mentioned earlier, like a lot of states are watching how Kansas is doing that. And when I hear that, it gives me pause, like, are we smarter than everybody else? You know, like what are they looking for? What are they expecting to see? And it sort of sounded like you said that integration model is probably are there any others that you are concerned about? I mean, what are the biggest challenges? I can see how this is a real benefit to Bert Nash, but I'm interested how the rest of the community, the rest of the providers might perceive this.
Yeah, so I think that part of the reason that we're in the spotlight, right, is like we've had both Missouri and Oklahoma have been demonstration states and have had CCBHCs for 10 years. And there are I think 8 other demonstration states in the country that have had CCBHCs at some level. Most of those states haven't implemented CCBHCs as aggressively as Kansas is attempting to do it. A lot of them have sort of piloted some projects here and there and eased their way in. We have a 3-year rollout compared to the 10 years that the demonstration states have had. And we also, I think, because we're going to be the first ones to do this in our state plan amendment and provide the service statewide, that's going to make us unique. And so I think what other states are looking at us for is to see, one, how successful we are with the implementation and the rollout. 2, how CMS reacts to our application for the state plan amendment. And then also in what the overall impact is on things like our behavioral health workforce. A large part of the reason that this is a really great program is that it should allow us to be more competitive in terms of the salaries that we're able to offer to staff at community mental health centers, and hopefully allow us to attract talent and workforce in a way that we haven't been able to do in the past. And so I think those are probably the 3 biggest challenges. One is, can we attract the workforce that we need in order to successfully implement? 2, can we structure the system in a way that allows for the reimbursement to be effective? And 3 is, can we do this in a way that CMS basically gives us the approval and sort of the satisfaction of doing this statewide first? And I do want it to give you a little pause because it's a big deal, right? And there are potential, roadblocks and hurdles along the way that we might run into, but we're doing our best to make it as smooth a runway as possible for everyone. We've got a team that we've assembled and hired at KDADS that work with the CMHCs on their application process for certification. We've contracted with Mercer to support our state plan amendment processes and also to facilitate our cost reporting mechanisms. We're using a lot of what's already been created for the demonstration states in order to prevent from having to reinvent the wheel on some things. And we've been working with NatCon, the National Council on Mental Wellbeing or Health Wellbeing. I'm not going to get it right. I just always call them NatCon. But they're the sort of the national experts that have created the Ccbhc Success Center for the nation. And so we've been working very closely with their technical advisor team, or technical assistance team, in order to really kind of put us on the best footing possible with CMS. We've been engaging with CMS in what we call an informal review process, where we've presented them with drafts of our state plan amendment, and they've given us some informal feedback, and we've incorporated that and gone back and forth. And I think we're making good progress and headway on that. So it's a big effort, and it caused us to do a considerable amount of reorganization in order to get to where we are today with the resources that we feel like we need as the state agency to support what's happening at the local level. But I do think it's a really good opportunity. And then, like I think Patrick said it earlier, that Bert Nash is really in a good position to do this in the time frame that they're proposing, largely on account of the fact that a lot of these other services and planning has already been going on in the community and already has the support of the voters and the residents here in Douglas County.
Yeah, and that's a nice tip up for my last question, which is sort of around, and I don't think Bob's here.
He's
But-
online.
Oh, is
yeah.
he online? I'm sort of interested. I know that we've done a lot of work about some behavioral health leadership partnerships that exist in the community. And I know Patrick and Stephen presented to that group maybe a couple of weeks ago. Is that about right, gentlemen? And I'm interested either to hear from Patrick or Stephen, or maybe Bob or Sarah, sort of what the initial reaction is from those other behavioral health partners. How is the hospital feeling at the 50% level on the crisis? How are they feeling about that? This feels like a lot like Bert Nash now would hold a lot of the cards here in that arrangement. Maybe I'm misrepresenting that.
Yeah, I'm not sure we necessarily hold all the cards or
Mhm.
more of the cards. I think what we have is an opportunity to bring in some additional funding that helps support the system differently and better. Any change makes people nervous, especially if it looks like an entity is going to gain more than others. And our approach, which has been supported by the county and our BHLC colleagues, is how do we look at the system and not create a service that already exists, but can we partner with somebody to do that? And so that's part of our trying to figure out is, do those fall under a DCO arrangement, or are those a care coordination partner? And that's, you asked a question earlier about the pieces, and that's the evaluation we're doing. We had to complete that needs assessment, and Marcia has taken that needs assessment and some additional work and saying, okay, what does our system have? Where are the gaps? Who could fill those gaps? And how do we best fill those gaps? It's our hope that we can, those that want to do a DCO, and it makes sense for us to do that DCO, that we can get there. That is a far more significant arrangement, obviously, than a care coordinator partner, where I just refer to you and we kind of coordinate that care, versus I am contracting for you to do this service that I am ultimately responsible for how well you do. And if you don't do it well, I'm the one in trouble, not you. So that contract has to be very clear, very specific, and the way they structure themselves may have to change a bit in order to be able to even do that DCO kind of arrangement. So there's some nervousness as we work through this, I'll be honest. But as the weeks have gone on, and we've gotten clarity and they've had clarity, more and more of the partners are saying, let's talk about that. We're interested in doing that and seeing where we fit. So that's what I can give you today.
Commissioner Kelly, this is Bob. I would like to amplify and build on what Patrick's saying. I think my sense, and it's just my sense, is that there's a tremendous amount of curiosity, and willingness to sort of sit in uncertainty to figure out what might be possible here. Because we know that the deck of cards metaphor, I think, is helpful. We know that you can't just continue to improve a behavioral health system by playing go fish, right? And so this is an opportunity to sort of reassemble the game in a different way, and there will be concerns and trade-offs. We've worked really hard over the last couple of years to build a coalition of partners that is so that it will be prepared to respond to opportunities, be flexible and nimble to adapt and change. So I think this is a really good test for the coalition, and it's a really great opportunity to push ourselves to discover how we can work together, how we need to work together, who wants to be in, who's not as interested in being a part of things. There is no way to approach this other than to roll up our sleeves and dive in and do our best for the members of the community, because there's a lot of potential here if we continue to do what we've done, which is to work together to build trust and to figure out what our relationships need to thrive.
And that really builds on kind of what I was hoping to say, and a little bit of my question would be, Douglas County has stepped in and provided substantial local support for behavioral health services in the absence of state and federal partners for decades. What that means is, in addition to is that you have a group of people and you have an organization that has a passion and interest and vision for how this work is implemented. So Marcia's last slide about, how do we get involved? What kind of feedback is what I'd like to hear more about? What is is there a more formal process for engagement? And how do we link up, projects underway through the Criminal Justice Coordinating Council and Behavioral Health Leadership Council to make sure it's a part of this vision?
So to date, we've had two different opportunities to engage our community partners in this process and to introduce them. One, to introduce them to the idea of what this is about, and then a follow-up meeting. So right now we're receiving feedback from them and interest from them. I know I've had some conversations. I'm sure Marcia has, Stephen has. I know Stephen has had several conversations of partners saying, let's explore this more. Here's how we think we can fit. We actually have one of our partners in the community that already has a DCO arrangement with another entity in the state who's a little bit further along in the CCBHC process than us. And I think the fact that they have it is bringing some comfort level to some of the others who are saying, okay, I think we should explore this. So we have already engaged them before we had a chance to even come to you.
But what about
answer all of it or not?
Well, I'm more curious, like, how does the county more formally engage in that process?
Yeah, and Sarah, what I'd say from my part is, like, I've been working with Bob and reaching out to Bob occasionally when there's things that come up where I think we're running, close to the same track on this stuff. And so I'd be happy to have, any dialogue with the county that the county wants to have with KDADs around CCBHC stuff. And I might be able to bring in partners from KDHE to talk about that as well.
And I don't know if that's what needs to happen. We have a great partnership with Bert Nash. I guess I just want to make sure that, as we're thinking about this, how do we make sure we're integrated into that conversation?
Sure.
Yeah, I think because Bob, were you going to say something? You lit up there for a second.
Yeah, I appreciate Commissioner Brown saying this because I think there's a lot of benefit for additional ongoing conversation with KDADs, Bert Nash, and the other partners that are bringing things like 988 and mobile response, ACT and AOT. There are a lot of pieces of this that are going to be supported by the state in ways that we didn't, envision as possible a year or two ago. And so, like I said, I appreciate Commissioner Brown, the communication paths that we've started around these issues specifically. And I think we just want to be, real intentional about making sure that we're continuing those conversations as the community mental health center is transitioning into the CCBHC model so that the community is able to benefit. And when I say the community is able to benefit, Douglas County is really seriously invested in improving our behavioral health system of care for the people who live here. There will be opportunities if the state is supporting things that in ways we didn't anticipate, that we can do some other things at the local level. And it's important for the county to really understand, what those opportunities are as they evolve. I don't know if that makes sense or speaks specifically to the question. I just think yes to more ongoing conversation and regular communication.
Sarah's nodding her head, so I think it did answer. And what I will say is we are putting on a different set of glasses with the CCBHC. So all the things that we do, and so many of the conversations we have with Bob and our partners will be looked at differently in like, hey, what's possible here? Can we shift this over here? And in some ways it might be we have to shift it, but it's really, to me, more about what are the opportunities to shift it so that, again, we can better coordinate care, bring down more federal dollars, and take the dollars that this county has invested and continue to invest in new things in behavioral health that really makes us what is already an example county in the nation, an even better example, and place that people will continue to come to look at what we're doing and how can they emulate that.
This
Yeah, and
is-
I think the other thing, go ahead, sir, sorry.
This is Commissioner Portillo, and I just want to say, Patrick, I really appreciate that framing of we're looking at this through a new lens. And I really appreciate Commissioner Brown, you being here and kind of talking us through this. I think that is going to take a lot of education for our community, because a big part of what we're saying, we know this is part of our values as a community to care about mental health, to make sure that we are providing the best services possible. It's a big shift to say this is now the model that we're using to integrate care across our community. I love the idea of bringing in the most federal dollars we possibly can, because that helps our local dollars go further. And that's been a priority of this commission, a priority of our state. And so I want to see that really work. But I think that that's where we're going to need a lot of education to help community partners and to help the general public understand this shift means that we're looking through a different framework so we can bring in federal dollars and make our local dollars go further. And I think part of what Sarah's question was getting at is how do we make sure we're bringing the community along
Yes.
in that conversation, in that process?
Right.
So,
that
and
will-
how do we explain this in a way that maybe includes a few less acronyms?
Well, yeah.
That's always
unfortunately.
hard when it comes to
Yeah,
federal
unfortunately,
dollars, I
We're
know.
so good with acronyms. So part of it will be is through that process Stephen has talked about in terms of our CARF and our strategic plan, which was adopted this week by our board. So we'll be sharing that out with you here very soon. And actually we'll make it available on our website so you can see what we're doing and how we're making progress through the community listening sessions and our ongoing interactions with our partners more and more. This is an iterative process. This will be something that was something Marcia was a little concerned about. What will I do once we're certified? I said, that's when the really cool innovation is going to start. We just got to get there. And then we get to do a lot of really cool things over the next several years. And that'll be by getting more and more feedback and partnerships with our community partners and the people we serve, because they will inform us as to what else they need from a behavioral health system of care. And if we can work with KDADS and KDAD says, yeah, that sounds like a great idea, let's include that, we can get that in place. So.
This is Commissioner Reed here. Any further questions from fellow commissioners? Okay, great. Thank you all so much for coming today. We really appreciate the time and effort you put into boiling this down for us, giving us a good executive summary of how we got from where we were to here. I'm pretty excited about the opportunities and we really appreciate your time, and thanks for making sure the public is aware that this is in progress also, and we can continue to use our meetings as an opportunity to, like Commissioner Portillo said, continue to educate the general public about what these changes means and what the opportunities are. So thank you again for your time. Just as a reminder for anybody watching, our work sessions, we are just for informational purposes only. We don't take any action. So with that, we will break for now and reconvene at 5:30 for our general business meeting. Thank you.